Hello, and welcome to the October episode of the Axial Spondyloarthritis podcast series. Alongside this podcast, we'll be bringing you RA and PSA podcasts and monthly side decks to help you to keep up to date with the latest research and publications in the field of axial SPA. My name is Sofia Ramiro. I'm a consultant rheumatologist and senior researcher at Leiden University Medical Center and Zuiderland Medical Center. And today I am joined by Hideto Kameda, Professor of Internal Medicine at Toho University, and Atul Deodhar, Professor of Medicine and Medical Director of Rheumatology Clinics in the Division of Arthritis and Rheumatic Diseases at Oregon Health and Science University in Portland. We hope you enjoyed this episode of the AxSpA podcast. If you would like more information on the paper we discussed today, please head over to the Immune-Mediated Inflammatory Disease Forum at the www.imidforum.com, where you can find more full information and full slide summaries of these publications. Hideto, please, you can take it over.
Okay, thank you, Sophia. We will be discussing one paper today in which the authors investigated the efficacy and safety of IV secukinumab in patients with active axial spondyloarthritis. Now, over to you, Atul.
Thank you, Hideto. This paper is a recent publication from me and my colleagues titled Efficacy and Safety of Intravenous Secukinumab in Patients with Active Axial Spondyloarthritis, results from a randomized placebo-controlled phase 3 Invigorate-1 study. The background of this study is that secukinumab has been shown to be effective and well tolerated for patients with radiographic and non-radiographic axial spondyloarthritis, as well as axial psoriatic arthritis when administered subcutaneously. However, the safety and efficacy of an all-IV regimen of secukinumab for the treatment of axial spondyloarthritis has not been previously studied. So the purpose of Invigorate-1 was to investigate the long-term efficacy and safety of intravenous secukinumab, which was 6 milligram per kilogram loading dose and 3 milligram per kilogram every 4 weeks thereafter in patients with active axial spondyloarthritis through 52 weeks. So this Invigorate-1 was a randomized double-blind placebo controlled parallel group phase 3 trial in patients with active axial spondyloarthritis, either radiographic or non-radiographic. And patients were randomized 1:1 to receive IV secukinumab, intravenous secukinumab, 6 milligram per kilogram at baseline, followed by 3 milligram per kilogram every 4 weeks, or intravenous placebo for 16 weeks. After 16 weeks, after week 16, patients who were randomized to placebo were switched to receive intravenous secukinumab, but they did not receive the 6 milligram per kilogram loading dose. They received 3 milligram per kilogram every 4 weeks thereafter, while patients who were randomized to secukinumab continued treatment through week 52. The primary endpoint was Assessment of Spondyloarthritis International Society, ASS 40 response at week 16. And the safety was evaluated through week 60. So, Sofia, you can tell us about the results of this study.
Sure, thank you very much, Atul. So in this study, we had initially patients were randomized either to IV secukinumab, as you explained, and in total 264 patients were randomized to secukinumab, and 262 patients were randomized to placebo. And if we look at the percentage of patients who have completed the entire 60-week study period, then we have 86% of the patients in the secukinumab arm and 88.9% in the placebo arm completed the whole study period. Now moving to the primary endpoint, the ASS 40 response at week 60. As expected, a higher proportion of patients receiving secukinumab met the primary endpoint, ASS 40, compared to placebo. So 40.9% of patients on secukinumab met ASS 40 response compared to 22.9% on placebo. And if we look at week 24, so after the placebo-controlled period, patients who switched from placebo to secukinumab, and they switched at week 16, they achieve as response rates that were comparable to those that patients originally randomized to secukinumab had achieved. All secondary efficacy endpoints were met at week 16, and the responses were sustained through week 52. Then we're talking about other disease activity outcomes, function measured with the BASFI, quality of life measured with the ASQUAL and SF36 questionnaire, and also sleep outcomes. They were all significantly, statistically significantly superior in or more reached in with secukinumab compared to placebo. Now moving to safety, the incidence of adverse events of interest was low among patients receiving IV secukinumab, with actually no new safety signals identified. Which were the most frequent adverse events up to week 16? We saw COVID-19, which also has to do with the time period in which the trial was run, diarrhea, nasopharyngitis, upper respiratory tract infection, and headache. Actually, there were no new or unexpected safety signals that were observed with intravenous secukinumab. Hideto, I think we can take the main take-home findings of this study. Over to you, please.
Okay, thank you, Sofia. So what can we take away from this paper? In conclusion, IV secukinumab demonstrated significant efficacy compared with placebo, with improvements in disease activity and quality of life sustained through week 52. And the findings align with previous studies on SC secukinumab, indicating consistent efficacy and safety profiles. And the introduction of an IV administration route for secukinumab offers flexibility in treatment options, addressing patient preferences for administration routes. So I want to discuss about at least 2 points. First, the FDA-approved dosing regimen of IV secukinumab is 1.75 mg per kilogram every 4 weeks, with or without a 6 mg per kilogram loading dose. And of course, second point should be the comparison between IV versus SC secukinumab and the differentiation in our daily clinical practice. So now over to you, Sofia.
Thank you very much, Hideto. Very relevant points. Well, I start with the second one, simply because I think that a comparison of the efficacy between the intravenous and the subcutaneous formulation is, in my opinion, not really an unmet need in the field. I don't think we have previous studies where we have molecules that have also been approved intravenously and also subsequently subcutaneous, and we do not have comparisons between them. I think the purpose here is not the comparison between them, but having demonstrated efficacy for each of them and safety, of course. And this allows patients to have options. Specifically with the case of secukinumab, we did not have IL-17 inhibitors intravenously before. So this gives us an option of having intravenous treatments for these patients. And we did not have an intravenous option approved for patients with non-radiographic axial SPA. So this creates an opportunity for these patients. This makes me also think, and I would like to hear your thoughts about your practices, which are the patients to whom you offer intravenous, or who are the patients that in your experience prefer to have intravenous treatment? Well, in the Netherlands, I would say that the vast majority of patients prefers, what I'm used to seeing is the vast majority of patients prefers subcutaneous treatment, where they have the possibility, especially younger patients that work, have the possibility to administer themselves. But there is an important group of patients, which are the patients in whom we may doubt about the capability of the patient to self-inject, or patients that do not want to self-inject, and patients in whom we may doubt about compliance. And I would say that the latter group is really the one that I really give preference to intravenous treatment. So in that sense, as I started by saying, I think it's good to have an option of an IL-17 that is also an inhibitor, that is also IV, and also an option for patients with non-radiographic axial SPA. And before going to your first point, I stop here so that we discuss these points, if you agree that. So maybe Atul can comment on these aspects.
Yeah, no, I agree that all this time, the only IV biologic that was available to treat axial spondyloarthritis has been TNF inhibitors, either infliximab or golimumab. Those are the two available. And we did not have another a biologic or novel therapies sort of available for axial SPA in intravenous form. So this certainly gives our patients an option. And I fully agree that if I'm worried that the patient may not be, the reason why they're not doing well is because they may or may not be receiving the drug and they're not compliant, then IV is important. There are two other issues in the US, and I see in my practice. One is unfortunate patients who are homeless and they're living in their car and they don't have a refrigerator and they don't have a place to keep their subcutaneous injection, which is really sad situation, but I see those occasionally in my practice. And the second is the insurance. Strangely, Medicare, which is the major insurance here for patients above the age of 65, or even younger patients less than 65 who are disabled for some reason, and they're getting Medicare, they are on Social Security, etc. Medicare, for some reason, likes, or I shouldn't say like, but they reimburse in a better way for IV. And so that's another, our hands are tied in various ways when you are practicing, quite apart from doing scientific medicine, the realities of life set in. And this is one of the realities of life that when I'm seeing seeing patients in my clinic, what will the patients have that is least out-of-pocket expense? So those are the two issues where I would be using this this particular drug. And if you want, I can talk about the 1.75 as well, but then you had some comments as well. So go ahead. I will reserve my comment for the 1.75 milligram per kilogram dose.
Okay, so in Japan also many patients prefer subcutaneous injection by themselves. And so only a very small portion of patients prefer intravenous infusion at hospitals. So it's very rare cases, but it'd be better for extremely high body weight patients for IV per kilogram. And also we need many options, so that may be fine. Okay.
Yeah, that's a great point. Patients who are overweight, then this is milligram per kilogram, and that's better than a fixed dose of 150 milligram, which is one injection, of 300 milligram that is also available. So
yeah, and also we can use the IV infusion as a loading, which was done measure 1 and measure 3 trials.
Right. So I'll quickly, if that's okay, Sofia, I can talk about this 1.75 milligram per kilogram dose. And so since taking a step back, FDA has this program going on since 1990s for drug development. And this one is called MIDD, which is model informed drug development. This is one way that they try to reduce the cost of drug development. This is the FDA. And if you know the drug's pharmacokinetics, what is going to be the highest dose and when that will be reached and when will it be excreted, etc. Based on the clinical models, statistical models, they can approve the drug if the drug has already been shown in few other studies, in actual practice, head-to-head studies with a placebo, etc. So the case in point here is secukinumab. Secukinumab has undergone multiple trials in axial spondyloarthritis and psoriatic arthritis, and radiographic, non-radiographic, etc., subcutaneous. And they know 150 milligram dose and 300 milligram dose. And as Hideto, you said, in measure 1 and measure 3, they used IV. So there are a lot of pharmacokinetic data is available. So, when Novartis went in front of the FDA and said we are going to do a clinical trial purely on IV, they were allowed to do this 6 milligram per kilogram, 3 milligram per kilogram. And then FDA looked at the pharmacokinetics of 3 milligram per kilogram Q4 weeks and 6 milligram per kilogram loading dose. They discovered that the IV actually was giving a much higher serum concentration compared to what FDA was used to see with 150 milligram and 300 milligram subcutaneous. And FDA is risk averse. They don't want to take any risks, even though nothing was shown, no new risk thing was shown. They ultimately decided that no, this is too high. And then without doing any studies, but based on the clinical models, this is again, this is this model-informed drug development. They gave an option to Novartis that we can allow your drug to come into the market in the US or elsewhere, well, US, 1.75 milligram per kilogram, because the model shows that 1.75 milligram per kilogram has a similar level that 150 and 300 subcutaneous we are used to seeing. If you're not happy with this, then do a study and show us that 3 milligram per kilogram is better than 1.75, and that will add, I don't know, $100 million more in another 3 years for your drug to get approved, etc. So Novartis took this chance and said, okay, well, fine, we'll accept it. And this is one of the ways the drug development cost is kept down. And but that raises a question whether 1.75 milligram per kilogram is really, or how good is this dose? So your original point, Hideto, that if somebody is really overweight, this is not a pretty big dose, but then still it is milligram per kilogram. So hopefully they will get that 150 milligram subcutaneous, whatever that would have given them the serum level.
Yeah, thank you very much, Atul, for this very comprehensive explanation. Indeed, I understand and I knew about it. I have the same questions that you shared with us, which is this efficacious enough? But on the other hand, the other side of the coin is the experience with previous intravenous drugs that are often approved at high dosages. Think about, for example, tocilizumab in RA, and from which we learned a lot in the COVID time as well. And pharmacokinetic studies have shown us that efficacy is assured even with much lower dosages. So often approval dosages are much higher than what is the minimum necessary. And this also shows that FDA required the dosage to be reduced indeed to be risk averse, as you have explained, Atul.
Yeah. Completely changing subject, but on the same study is uveitis. Because, and we have discussed this on this forum in the past, that IV secukinumab there was a separate study on uveitis. They had 3 studies on subcutaneous, and that didn't work in uveitis as a treatment for acute anterior uveitis, but the IV worked. So we were pretty curious to look at uveitis in this study. There were hardly any uveitis episodes in the study, but the exposure adjusted incidence rate was 1.8, which is neither here nor there. So it doesn't really, if somebody is looking at this study to say that whether really IV secukinumab is good for acute anterior uveitis of axial spondyloarthritis patients, this study did not really, because there were not enough patients who got uveitis, luckily, to compare really with placebo. But I just wanted to make that point because people might be trying to search for this nugget into this study.
Yeah, I think that's a very good point, but that also brings us to emphasize that it's very challenging to assess the efficacy of a drug on uveitis when we're talking, especially when we're talking about relatively short-term trials still. It's a manifestation that occurs not very frequently, especially only over a fixed period of time. And then a simple difference in one patient makes a huge difference in the incidence rate. So yes, I think we have to interpret it with some caution, as you are As I notice in the way you are saying it, Atul, because yes, we have to have some caution in this interpretation.
Right. The IBD numbers, we were reassured. And again, the study was done with 6 milligram, 3 milligram, not 1.75 milligram, with these higher concentrations that FDA didn't really like in the serum levels. Still, over that 52-week period, the IBD, inflammatory bowel disease, exposure adjusted incidence rate was still 0.8. That 0.8 has always stuck into my mind with all IL-17 inhibitors, including ixekizumab. And I don't know about your practices, but I use these numbers in my clinical practice to counsel the patients, because patients hear about these kind of things. And I tell them that if I treat 100 patients like you over the next 1 year, less than one patient in that year would have problems of inflammatory bowel disease. This is the way I kind of explain to them, because 100 patient years, they don't really understand what that means. But if you explain that, and then they can accept, and in a very short sentences, you're able to then kind of counsel your patients in clinical practice about completely changing the subject about myocardial infarction in JAK inhibition, or IBD here, or uveitis, or whatever you're talking about. And numbers kind of help patients to make the decisions, shared decision making that we always do.
Yes, I totally agree. And from that patient over a year, 100 years, I would say 100 patients in a year, but both things are correct. I would even say we cannot be sure whether that is due to the treatment. It can simply be the natural history of the disease, and that patient would have it anyway. So I think that data are reassuring, as you are saying. We are not seeing any signal on exacerbation of IBD or important new diagnosis of incidence of new diagnosis of IBD. And I think this also has to do with the fact that we, of course, are not treating patients who have active IBD with IL-17 inhibition. And in those that do not have active IBD, it does not seem to be an issue, as we are seeing, as we have been seeing throughout the years, and with different IL-17 inhibitors. So totally agree. Okay, so I think, do you want to add anything else, Hideto?
No further comments. Thank you.
Okay, so I think that this is we are bringing this podcast to the end. Thank you for joining us for this AxSpA podcast, brought to you by the Immune-Mediated Inflammatory Disease Forum. We really hope you found it useful, and if you did, please don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. And if you want to read more about what we have discussed, head over to www.imedforum.com, where you will find summary slides for this paper. See you next time.